Not a chest surgeon, but I'll look chest injury from the trauma surgeon perspective. I bring greetings from All India Institute to all of you. And if we look at the trimodal death distribution in trauma, I think chest trauma is one which might be responsible for more immediate deaths because of major vascular injury to the vessels of the chest, and of course cardiac injury and severe pulmonary injury. But what we are looking at, that most of these patients who survive onslaught immediate on the scene of accident would then land up in our EDs in various degrees of hemodynamic instability or stability, and then we have a challenge on preventing early deaths. And of course, if we can do that, then naturally the late peak, which is the third peak, which is because of sepsis, can be brought down significantly. And that is what ATLS actually does. That if you can take care of the patient in immediate few hours after trauma well, then these peaks can be reduced. Now, objective of this talk would be to briefly overview the chest trauma as it stands today, and of course discuss a little bit outline of bleeding into the chest, because in 15 minutes that's what I think I can do that, and look at the causes, immediate management and definitive management of these patients. Chest trauma is always sudden and dramatic, and if you look at, because of the seat belt, if it is enforced, then we are supposed to get a little bit higher increased rate of chest and abdomen injuries because of the fastening of the seat belt, but then we prevent many other serious injuries. And it is responsible for 25 to 50% trauma-related deaths, as was reported in this extensive review which was done a few years ago. And we need to have a very high index of clinical suspicion. And we also have to look at whether it's a blunt trauma or penetrating trauma. And blunt trauma naturally is much more common than penetrating trauma. If you see, there are some telltale signs of blunt trauma. If you see in this photograph, there are some abrasions, and that would indicate towards the injury inside as well, and one can also have sternal fracture, rib fractures, etc. This is one of the representative case who was brought to trauma center. You saw the patient lying on the table. I think Dr. Chavi would remember this patient. He actually anesthetized this boy who had severe injuries because this needle iron had gone through his epigastrium, through his stomach, liver, spleen, diaphragm and left lung. Now, if we look at the penetrating, is less than 30% patients require operation. And that is something good about chest trauma, that very few of them require actually surgical intervention. And blunt trauma, less than 10% patients require operative intervention. And majority of them, and that's a good news, that majority of them can be managed with simple measures like chest tube drainage, thoracic epidural for pain relief, physiotherapy, and they would recover if there is no other associated injury. Extent of injury can be in the chest wall, in the pleural space, in the lung parenchyma, various degrees of lung contusions, and of course mediastinum. And it is not limited to the chest only, and I must emphasize here that the whole of upper abdomen, which the chest encases, is the liver on right side, spleen on left side, stomach, pancreas, and we need to remember this, the retroperitoneum in that area. And we need to remember, whenever we are managing a patient with chest injury, whether it's penetrating or blunt, we must remember that these patients can have abdominal injuries, what we call intrathoracic abdomen. In that abdomen, they can have severe injuries. And the pulmonary contusion is one single factor which would lead to hypoxia, hypoventilation, hypovolemia, ventilation perfusion mismatch, changes in the intrathoracic pressure relationships, and metabolic acidosis, what you just heard Dr. Prasad Rajan's telling about. And this is one single most important problem in many of these patients who are severely injured, the severe pulmonary contusion, or elderly patient with chronic obstructive airway disease. Presentations can be with various rib fractures, clavicle, scapula, sternum. They can have pneumothorax, open or closed, unilateral or bilateral. And of course, we also have to be consciously looking for, is there any tension pneumothorax, hemothorax, hemopneumothorax. And these are the presentations. Pneumomediastinum can be there, pulmonary contusions of varying degrees, myocardial contusion, and diaphragmatic rupture. Now, diagnostic tools are simple as regards immediate management of these patients, and if you look at the ATLS protocol, we are only allowed to do a chest X-ray in supine AP, and because these patients are critically injured, and we can get some signs on chest X-ray. And of course, these days now, FAST, what is focused assessment sonography in trauma, is becoming very popular in detecting cardiac tamponade, blood in the pericardium, and that it's becoming a investigative tool of choice in EDs. Then of course, once we hand over the patients to definitive care surgeons, depending on the indications, contrast enhanced CT scan chest or CT angio can be done in stable patients. Again, it should be done without wasting a lot of time, and of course there should be possibility of having reconstruction of these films. And of course, if there is an indication, one can also do DSA. One thing I want to highlight here, that these patients should not become victim of modern imaging technology, and we need to use the right track for these patients, where we have ABCDE, which is airway, breathing, circulation, disability, where I'm talking of neurological disability, and exposure, environment, and temperature, not airway, breathing, and then sending these patients early on to CT scan, and patient has not been stabilized, leading to patients dying in the CT room, and naturally, you know the consequences. So, management primarily revolves around managing ABCs, because chest trauma can have, because there are airway problems, breathing problems, circulation problems. And our objective is to recognize and address these conditions, and these are life-threatening, mind you, and should be very, very promptly. As I mentioned, non-operative management works. Simple chest tube drainage works in majority of these patients with adequate analgesia, which I am happy to tell that we are very proactive. Our anesthesiologists are very proactive. ICU caregivers are very particular about, and this thoracic epidural is serving as a boon to these patients, and naturally then chest physiotherapy also becomes very much simpler. And of course, serial physical examination, as it would apply to any abdominal, it applies to thoracic injury as well, and any trauma patients, serial physical examination would rule out any missed injuries in these patients. I would say that one should not do exploration if we do not have a blood bank, good ICU, experienced anesthesiologist, trained thoracic surgeon, and if these things are not there, I think better these patients are transferred to appropriate facility where these can be managed well. Now, bleeding can be because of the internal memory or intercostal vessels in majority of the patients, or it can be from the pulmonary vessels or lung parenchyma in 10% of the patients. And of course, great vessels, heart, and can be injured in the mediastinum and can give rise to blood loss. As I mentioned, intercostal tube drainage, simple, works in majority of the patients. Indication for exploration would be if we get 1500 ml of blood drained in insertion of the chest tube. If it continues to bleed more than 200 milliliters per hour for 2 to 4 hours, or there is cardiac tamponade, or there is injury to aorta or major vessels. Thoracotomy can be done by posterolateral approach, anterolateral approach, or thoracosternotomy or midline sternotomy. This is commonly used for trauma, in unilateral trauma. This incision is used, which is when we are suspecting cardiac injury, the clamshell incision, and not this midline sternotomy is not commonly used in thoracic trauma. This is just a one representative stab penetrating injury to the chest, and you can see, although its focus is not there, but you can see the knife, and it was removed under vision. Aortic rupture and great vessel injury are the most responsible for the death on the scene or on the way to hospital because they lead to abrupt deceleration or compression injury. And again, they are often rapidly fatal. Only 10% survive to the hospital. 90% who reach hospital alive, they die. They need, the best chance can be by aggressive resuscitation. And if you look at these figures, I was going through a review where they say penetrating injury, if you do emergency thoracotomy, chances in salvaging and penetrating injury is higher, up to 9 to 12% average. Some reports have also salvaged about 38% of these patients, but survival rate for these patients in blunt trauma is very, very dismal because of the magnitude of the injury basically. This is one of the patients who had aortic disruption, and it was a contained one, and that's why he survived and we could do a aortic stenting subsequently. Cardiac injuries are of course highly lethal. Again, penetrating is more than blunt, mostly ventricular, right more than the left. Blood would be in pericardial sac, occurs most frequently with penetrating injuries, and we also have to recognize pulseless electrical activity. If we diagnose cardiac tamponade, and which is simpler nowadays with the with the ultrasound, with the help of ultrasound, they require volume resuscitation, pericardiocentesis immediately, and of course then surgery must be done soon after the pericardiocentesis has resolved for temporarily. Survival rates for emergency room thoracotomy actually they depend on the serious severity of the injury. And of course, highest survivors one would expect in the resus bay rather than on the street or in the helicopter or in the ED. This just, I'll share with you this one device. Audio भी होगा इसका. Can you just dim the lights, please? Can the light be a little bit dim? This was one of the patients who sustained a very severe chest injury in a very bizarre accident in Delhi. This was one of the patients, the rescue work which I had not seen before in my career. The patient was brought in the car to the trauma center actually. Both the patients, this is the driver who was impaled in the seat. These two rods had penetrated through the windscreen, through the right chest, through the right arm, through the seat, and went into the thigh of the other gentleman sitting on the back of the car. And it was lifted by the crane, and we felt that in retrospect, the pre-hospital rescue workers did a good job, presence of mind, that because they could not extricate him there, so we saved some time by the time he was brought to trauma center, and then that is where the fire people came. They extricated this boy, and naturally no investigation could be done because he couldn't just lie down. So he was shifted to OR, and he was actually anesthetized in sitting position, although he was severely tachycardic, he was hypotensive, and he had lost significant blood in the process. And then the thoracotomy was done. आवाज बढ़ा दे. Still I have some time. I'm following my watch. Yes, I started 2:20. So he recovered and he consumed about 59 units of blood and blood products on this boy. And we discharged him about 5 weeks later from the hospital, and we salvaged his right limb as well. This is just to share with you one cardiac injury, severe. This is an interesting patient where this boy came nearly 8 hours after his injury, and he had lot of blood in the chest, and when we resuscitated him to do a CT scan, he had a ventricular rupture, and this was tackled, and this boy was discharged from the hospital. And we can also manage diaphragmatic injury now in acute and with minimal access approaches. This is just one acute diaphragmatic traumatic injury which can be done. I'll not go into the data because I'm running short of time. So I'll just say that most patients, as we have discussed, males are predominant in any other trauma, and road traffic accidents are the majority reasons for the chest injury. Hemothorax is one which is present in majority of the patients, and they require chest tube drainage. There can be associated injuries, as I have already highlighted, and we must keep in mind about upper abdominal injuries to the liver, spleen, and of course the pelvis and extremities also. Yeah. And this is another patient, I think I'll skip that. And this again, he had atrial rupture, and he was also managed successfully by us. So chest trauma is a significant cause of morbidity and mortality in polytrauma patients. We have to have a high index of suspicion. In majority, hemothorax can be managed with chest tube insertion only. Thoracic epidural analgesia is very effective for pain relief in these patients. Accident and injury prevention is a huge challenge, and it's a social responsibility, and we all need to do that wherever, whosoever we are working in any hospital, we should work towards that. Thank you very much.